So let us approach the clinical conditions that affect the pectoral girdle. So what are the sites of involvement? The sternoclavicular joint, that's one. Then the clavicle itself, the acromioclavicular joint, the glenohumeral or the shoulder joint, the scapula, and the upper end of humerus. So this is it. Sternoclavicular joint is here, clavicle is here, acromioclavicular joint, scapula, shoulder joint, and upper end of humerus. What are the common nature of lesions that involve these joints? Tuberculosis of the sternoclavicular joint is an extremely rare condition, but subluxation is very common. Then the clavicle, the commoner condition is fracture of the clavicle, and the rarer one is craniocleidodysostosis, where in the cranium and in the clavicle the ossific nuclei fail to fuse, that is dysostosis. Then the acromioclavicular joint, there is subluxation again, and that is usually traumatic. It needs surgery. Then the shoulder, the commonest problem is the dislocation. This will take most of our time. Periarthritis, impingement syndromes, tuberculosis, and tumors we will deal in the next video. In the scapula basically descends, and if the levator scapulae, which lifts the scapula, is fibrosed or short, then the scapula doesn't descend, it is undescended, and it leads to high shoulder, which is the springal deformity. When the levator scapulae becomes bone, then it is called as the omovertebral bar. The omo means scapula, and that connecting it to the vertebrae. If the condition is bilateral, then it is called as Klippel-Feil syndrome, and the winging of the scapula because of the paralysis of the serratus anterior is another common clinical condition that we encounter. Upper end of the humerus, there are fractures and there is avascular necrosis, and these are the common conditions that we have to remember or manage in orthopedics. And what do we have to answer about them? We have to be able to diagnose them. What is your diagnosis? Then why do you say so? Any differential diagnosis? Why not that? How would you investigate? How would you treat? What is the prognosis? So the sternoclavicular joint pathology presents with usually a subluxated sternoclavicular joint. So you see, this is the glenoid. This is the sternal articulation. We'll make it thicker. So the sternal articulation, and this sternal articulation, the medial end of the clavicle is in the articulation, but here the medial end of the clavicle has moved up. This has to happen if this meniscus here holding the medial end of the clavicle down has ruptured, and the costoclavicular, that means the ligament connecting the medial end of clavicle with the first rib has ruptured, or the subclavius muscle is stretched or damaged, then this will happen. You will be able to feel the end of the clavicle as compared to the opposite side, and this is prominent. Usually the patient presents with slight pain and this abnormality, and basically you don't have to do much in this, but you have to remember that this is because of the failed costoclavicular ligament subclavius and the medial meniscus pathology. And the clinical diagnosis is by comparing with the normal side. Investigation is X-ray, and you leave if it is asymptomatic or mildly asymptomatic. And it's a very important joint, so you don't try to fuse it, because that will prevent overhead abduction of the shoulder. And all movements of the scapula will go. That means protraction, retraction, rotation, derotation, depression, elevation. All are occurring in the sternoclavicular joint. So don't take this joint lightly. Then there can be a tuberculosis, which is the lytic lesion on the medial end of the clavicle. Usually there is an insidious onset of tenderness, thickened and swollen sternoclavicular joint. You can see that difference on the right and the left side. And here you see that the medial end of the clavicle is almost destroyed or absent as compared to the opposite side. So this is the clinical picture of a sternoclavicular joint tuberculosis. And of course the diagnosis is, if you can see it on histology, or you can or it responds to antitubercular treatment. So these two things, response to antitubercular treatment and histological confirmation, would give you the diagnosis of tuberculosis. Response to ATT, confirmation by histology or culture, confirms the diagnosis. Now we move on to a very common problem, and that is the fractured clavicle. There will be a history of fall on an outstretched hand. There will be pain, swelling, deformity, and loss of function. You have to remember that this happens in every fracture. Pain, swelling, deformity, loss of function. There is a tender swelling on the clavicle. Maybe you can elicit some crepitus. And the acromion of the affected side is nearer to the sternoclavicular joint. You see, here is the acromion, and it is nearer to the sternum because there is overriding of the clavicle. So that almost confirms a diagnosis. Now, if the fracture is medial to the coracoclavicular ligament, then the medial fragment is free to go upwards. But if it is lateral to the coracoclavicular ligament, then this attachment of the coracoclavicular ligament to the medial end will prevent its displacement. So the fracture is basically of two types. One is stable, where the displacement is not marked, and the other may be unstable. Both type of fractures can be treated conservatively, but you have to confirm by an X-ray, AP view, and include both clavicles. A displaced fracture may need open reduction and fixation by plate and screw. An undisplaced fracture is treated by reduction. The reduction is that you place your knee in the interscapular space of the seated patient, and your assistant pushes both the acromion of both sides backwards and upwards. Then you tie a figure of 8 bandage which moves from the side. It moves under the axilla and then goes up and back, pulling the acromion back and up in relation to the medial fragment. And this figure of 8 bandage would reduce the fracture. You have to, after the reduction, you have to look for any neurovascular compromise, and you retain it by a figure of 8 bandage or a brace. This is the figure of 8 brace that you see here. It unites in 3 to 4 weeks. The problems can be malunion and a lot of callus, which is called as the callus tumor. The usual site of fracture clavicle is the junction of the medial 2/3 and the lateral 1/3. Because it's a junctional area of the two ossific nuclei, the cancellous and cortical bone, the two curves, that means anteriorly concave and anteriorly convex, and weight bearing and non-weight bearing bone. So you are usually asked why it occurs here, but of course the more important point is whether the coracoclavicular ligament is attached to the medial proximal fragment or not, because that will prevent displacement. The differential diagnosis is craniocleidodysostosis, where the ossific nuclei of the clavicle, lateral 1/3 and the medial 2/3, have failed to fuse, and same way cranial sutures have also failed to fuse, thus the name craniocleidodysostosis. It is usually bilateral, there is no history of injury, it is painless, and the diagnostic sign is that the patient can meet the shoulder in front of the chest, that you can see here. And of course there's no clavicle, there may be no clavicle. Then we look at the acromioclavicular joint, and you see this acromioclavicle joint is between the acromion and the lateral third of the clavicle, the green one. And if the coracoclavicular ligament, coracoid is below, it's attached, it is holding the lateral third of clavicle in its place by a ligament, which is the coracoclavicular ligament. So if there is this medial end of clavicle goes up in relation to the acromion, then this coracoclavicular ligament must rupture. There is pain, you can feel a step, and then from the lateral 1/3 of clavicle you have to drill holes, pass an artificial ligament under the coracoid, and hold the lateral third of the clavicle down across a button by this artificial ligament. Sometimes this lateral end of clavicle will not go down because it will strike against the acromion. So you have to excise the lateral part of clavicle to an extent that it will go and align with the acromion process. So this is the treatment of acromioclavicular dislocation. Now the shoulder dislocation. Clinically, there's a fall on an outstretched hand, or a person may have grabbed a branch while falling from a tree, or there had been an epileptic attack, and there's pain, swelling, deformity, or loss of function around the shoulder. The 4 signs are: cannot reach the opposite shoulder, that is the Dugas sign. The bulge produced by the greater tuberosity is lost, so that you can touch the acromion and the lateral epicondyle by the same ruler. This is called as the Hamilton ruler test. The circumference of the axilla is increased, that is called as the Callaway test, and the anti-axillary fold is lower and the axilla is deeper, that is called as the Brandt's test. So these are the 4 tests, but sometimes you may feel a smooth bony swelling under the coracoid process, and this you can confirm is the head, because if you rotate the arm, the movements would get transmitted to the head. But if you feel creps while doing this, then you must suspect that there is a fracture dislocation or the fracture of the cervical neck or upper end of humerus. You must investigate the patient for fitness for anesthesia and surgery. Sometimes sedation and local intra-articular local anesthesia may be sufficient to reduce the dislocation. Before you start reducing it, you must rule out neurovascular damage. The X-ray of the shoulder AP view will give you the most of the diagnosis, but an X-ray of the shoulder in 60 degrees of internal rotation, X-ray of the shoulder AP in 60 degree of internal rotation would demonstrate you a fracture of the posterior-superior part of head, a flattened fracture, so that when there is even a little bit of rotation, this head can slide forward, and this lesion is called as Hill-Sachs lesion. It is seen on the X-ray AP with 60 degrees of internal rotation. Now you see that this depressed is the Hill-Sachs lesion, and this anterior marginal fracture of the glenoid labrum, glenoid, is the Bencart's lesion. So these two lesions have to be diagnosed by careful examination of the X-ray. Also, you must look at osteoporosis, otherwise you may produce a fracture surgical neck of humerus while trying to reduce the fracture. So it can be done under general anesthesia, but under local anesthesia and sedation it can also be done. Basic method is Cocker's method, which is traction. So this arm is being traction, and a towel under the axilla, there's counter traction. Then you gently externally rotate so that the head goes anteriorly to the margin. Then you adduct and internally rotate. So traction, counter traction, external rotation, adduction, internal rotation, and with a clunk the reduction can be achieved. The convexity of the shoulder is restored, and the person can now reach the opposite shoulder. So this is called as the Cocker's method. But if you think that you will produce a surgical neck of humerus fracture because of osteoporosis, or there is a fracture, then by a simple traction, counter traction, you create a space between the upper end of the humerus and the glenoid, and using the instep of a stockinged feet, you push the head in the glenoid cavity. You can rotate the upper limb gently, externally rotate it to facilitate the reduction. Now, if a closed reduction fails, then you have to do an open reduction. And in an open reduction, if the head becomes finally avascular, you will have to do a total shoulder replacement. Now, there is another problem with dislocation of shoulder, and that is called as recurrent dislocation. That occurs because the subscapularis and the anterior capsule is torn. So this you can strengthen by double breasting the subscapularis, double breasting, so that it becomes tight, or advancing it. So double breasting is called as putti plat. It's called as putti plat, and advancement is called as Edenhavenite. Then you can put the coracoid, you can screw the coracoid parallel to the anterior margin of the glenoid, so that it acts like a bone block and will prevent a recurrent dislocation. Thirdly, you can repair the Bencart lesion, the avulsion of the anterior margin of the glenoid from the anterior margin of the scapula. So that is called as the Bencart's repair. And in the Hill-Sachs lesion, you can attach or plaster the capsule and the infraspinatus into the Hill-Sachs lesion, which will prevent this lack of the articular surface to cause a recurrent dislocation. That operation is called as remplissage. So this is the remplissage operation. Now we will cover the upper end of the humerus fractures, periarthritis, some infections of the shoulder, and pain points around the shoulders, especially the impingement syndrome, in the next video. Thank you.